Welcome, everyone. Thank you so much for joining us this afternoon. We have a wonderful group from Lurie Children's Hospital who's going to talk to us about understanding BiPAP. We're really glad to have them here with us this afternoon. And it really came from an interesting sort of experience we had at annual conference this past year. So if anybody is tuning in who was in that teen and adult care breakout session at annual conference in Las Vegas, Maria will look a bit familiar to you. And we were engaging in this really great discussion around BiPAP and how sometimes it can be difficult to be compliant and it's not always comfortable and it can feel frustrating and you might not know why it's super important. And she enlightened us and we had some great discussion and we looked around the room that was very full. And I said, hey, would it be helpful to this group to have a whole webinar and just talk more about why BiPAP is important and how to be successful? And I would say almost every single hand in the room went up. And so we're really thrilled to have Maria and her team join us today to dig in more to why BiPAP is needed, what gets in the way of being successful with it, and how to increase compliance or that ability to successfully wear your BiPAP. So we're going to go through a few different perspectives on BiPAP. We've got Dr. Janaki Paskuradevan, who is going to come at this conversation from the pulmonologist perspective. Maria Gonzalez is a nurse practitioner who runs a BiPAP clinic. And then we've also got Ali Clark, who is a psychologist. And so I think that we've got a really well-rounded group to help us learn a little bit more today about BiPAP. As you have questions, we want to answer them. So please feel free to drop them in the chat throughout the webinar. And then at the end, we'll have an open Q&A session where we'll dig into that. And with that, we're going to go ahead and get started. So Dr. Paskuradevan, I'm going to hand things off to you to talk to us a little bit about BiPAP.
Perfect. Thank you so much, Rachel, for the introduction. We appreciate it. And we're so happy to be here doing this virtually to kind of get into understanding BiPAP, why we need it, what gets in the way, how to increase compliance. So as she mentioned, my name is Janaki Paskuradevan. I am a pulmonologist, a pediatric pulmonologist at Lurie Children's, and I am the pulmonary medical director of our neuromuscular program. I'm presenting with Maria and Dr. Clark, and they will introduce themselves a little bit more at the beginning of their portions of the talk. In terms of disclosures, I do have a consulting agreement with Catalyst Pharmaceuticals, but content related to this will not be discussed during the presentation. Dr. Clark and Maria do not have disclosures to report. The one additional thing I wanted to add here is that we do work in the pediatric world. So I think that is relevant as you hear some of our topic, and we'll do our best to provide things that also are relevant if you're outside of the pediatric world. The objectives we will cover today include to recognize why bilevel positive airway pressure, or BiPAP, is needed in patients with Duchenne or Becker muscular dystrophy, and when to start BiPAP, describe the benefits of BiPAP use and the risks of not using it, understand the challenges of BiPAP use and how a positive airway pressure or PAP clinic can help address them, identify key strategies for successful PAP management, including risk stratification, proper mask fitting, side effect troubleshooting, and family involvement in care, and then consider potential barriers to treatment. And then finally, introducing some behavioral strategies to help with desensitization to PAP usage and improve daily use. I will go ahead and start with the first two objectives to lay a background for the rest of the talk. So briefly to review respiratory disease in patients who have Duchenne muscular dystrophy and Becker muscular dystrophy. We know that respiratory muscle function and strength correlates very closely with the ability to walk. As the ability to walk independently is lost, the muscles involved in breathing become weaker. Once that ability to walk independently is lost, there is high risk of sleep-related breathing concerns. So this can include snoring and obstructive sleep apnea, though these can be present prior to loss of independent walking related to weight gain around steroid use or related to tonsil size, adenoid size. Other sleep-related breathing concerns include central sleep apnea, hypoventilation, which is defined as breathing low amounts of air or breathing slowly, which leads to high carbon dioxide levels due to the inability to clear that carbon dioxide when you're breathing out. And then hypoxemia, which represents low oxygen saturations. A sleep study is recommended once a person is unable to walk independently, as sleep-related breathing problems can show up and be present even when there's no symptoms that are noted by the individual. Over time, unfortunately, as weakness progresses, we know that this nighttime hypoventilation and hypoxemia start to occur while awake. So, how do we help breathing? When the muscles of breathing become weaker, we recommend starting something called bilevel positive airway pressure or BiPAP. BiPAP is a device that provides two different pressures. So there's a lower background pressure that is present when the patient or person is breathing out, and that pressure helps keep kind of the upper airways open, help make airflow easier. And then there's a second higher pressure that is delivered when the person takes a breath in, and that pressure helps expand the lungs. BiPAP pressure is delivered through a mask that goes over or under the nose. There are full face masks that cover the nose and mouth that are on the market, but we do not recommend those for home use. The reason for this being that for many patients with Duchenne, it is really challenging to self remove that mask. So, if there's vomiting or other issues in the night, we don't want a full face mask covering both the nose and the mouth, leading to risk of aspiration, which means spilling things into the airway. So when the person is on BiPAP, you actually trigger the machine to give that pressure that is set with each breath that you take. We also program a backup rate to kick in if a person is not breathing as often as we think is appropriate and safe, or if there's trouble kind of triggering the machine to give that pressure due to weakness. So how do we know when to start BiPAP with sleep? So there's actually a lot of different categories and criteria for starting BiPAP with sleep. So I'll kind of go through them kind of one by one. So the first is actually if there are signs or symptoms of sleep-related breathing concerns. So truly having any of these symptoms, waking up a lot at night, snoring, pauses in breathing, sweating profusely during sleep, having morning headaches or continuous headaches, feeling very sleepy during the day, difficulty concentrating, having decreased energy or shortness of breath. All of these symptoms in someone who has muscular dystrophy is a sign that you could start BiPAP just based off of that. We also monitor pulmonary function testing very routinely during clinic visits. And so, a forced vital capacity on the blowing test or spirometry that is less than 50% predicted is an indicator to start BiPAP. Additionally, the muscle forces that we test, so the maximal inspiratory pressure, if that's less than 60, that is a criteria that suggests that you can start BiPAP. We also look at awake saturations of oxygen, and if that's less than 95% consistently, or carbon dioxide is over 45 when you're awake consistently, that does meet criteria. So all of these things are reasons that allow you to start BiPAP. Many times, providers use these guidance and these symptoms to decide that that is a time that you also need to automatically get a sleep study beyond just the point of loss of being able to walk independently. So if the sleep study that's obtained has certain abnormalities, that's also how we decide when BiPAP is needed. So, an abnormal sleep study includes having a carbon dioxide over 50 for more than 2% of sleep time. And this is different than if someone does not have Duchenne. We look at much more time having CO2 over 50 that concerns us, but in Duchenne, it's 2% is enough. Having an increase in your carbon dioxide level by about 10 from what you do when you're awake for 2% of sleep time, having oxygen saturations under 80% for either 2% of sleep time or for 5 minutes in a row. And then if there's an apnea hypopnea index of 5 or greater, so apnea means pauses or stopping breathing, hypopnea means shallow breathing. So if there's a combination of those that occur 5 or more times an hour, then that also indicates the need for BiPAP. So how do we start BiPAP? And I will preface this with this can actually be quite variable based on state insurance requirements, your age being over 18, under 18, and what insurance requirements are related to that, as well as your provider preference. So one option to start BiPAP is with the use of a titration sleep study. So a titration sleep study is a sleep study that's completed on a BiPAP device. So in the pediatric world, you come into our sleep center, the BiPAP is placed on you after a mask is fit to you. And then throughout the night, your oxygen, your carbon dioxide, your snoring, all of those things are monitored to help determine the best settings. Once we determine the best settings, I then, your provider would then place the order for the study, and it would get delivered to your home. The downside of this is this may be the first time you've ever encountered BiPAP, and it is a device that can be a little bit challenging to get used to wearing. And so Dr. Clark will get into this a little bit more later in the talk. So in our center, whenever possible, our preference is actually to start the device at home. What that means is our pulmonologist will choose a setting based on clinical information and then order the device. The durable medical equipment company will come to the home, provide setup and teaching, and then we start with gradual desensitization. So in the MDA clinic during the pulmonary visit, we'll talk about some strategies to get used to the device and then also offer the referral to our PAP clinic that Maria will talk a little bit more about shortly. Then once the person is pretty used to using BiPAP, able to wear it for several hours in a row or throughout the night, then we'll obtain a titration sleep study to make sure we picked the best settings or if we need to make some adjustments. So one thing I also wanted to note that whenever we're starting breathing support for someone with muscular dystrophy, this really should be done as BiPAP. So those two levels we talked about with a backup rate in the background. Um, Continuous positive airway pressure, or CPAP, which many people hear about for treating obstructive sleep apnea, is really generally not appropriate in people who have Duchenne muscular dystrophy. The reason for this being that CPAP gives you one pressure all the time, and it does not give you any extra pressure when you breathe in that would help expand your lungs. So it doesn't really solve the underlying problem we're trying to address. And then of note, settings and BiPAP usage are reviewed at every clinic visit, and we do have to make changes over time to make sure we have the right settings as weakness progresses. And Maria will talk a little bit more about how we can review device data. So we just talked about starting BiPAP and using it at night. How do we know when we have to switch to using BiPAP when we're awake as well? So this is actually often guided by the person themselves, the person with the disease, when symptoms of difficulty breathing start to occur when they're awake. So often for my patients, I tell them, if you're having any symptoms during the day, you can use your BiPAP. It's there to help you. It's not going to be harmful. And so naturally, patients start to increase their time on the BiPAP. Other signs, like more specific criteria that tell us BiPAP is needed when awake, is if consistently your awake oxygen saturations or carbon dioxide levels are either below 95 or above 45, respectively, even if we've already confirmed we have good nighttime settings and there's good consistent nighttime use. Forced vital capacity on lung function testing, having an absolute volume less than 680 milliliters is also high risk for daytime hypoventilation and need for daytime BiPAP. Um, this next point about SIP ventilation and mouth ventilation is a little bit out of the scope of this talk, but it is an option, and that's what's pictured here in our photograph. When breathing support is needed when awake, this provides another strategy to get additional volume, help expansion of lungs that doesn't require wearing that nasal mask. So if this is something you're interested in hearing more about, certainly we can talk about it in the Q&A and something that your pulmonologist can help discuss as well. So the last thing I wanted to touch on was just the benefits of using BiPAP and then the risks of not using BiPAP when you have met the criteria, or what I call the indications for needing BiPAP. So some of the big benefits, so truly better quality of sleep. And I often tell my patients, you may not realize how poor of sleep you're getting until you start using the BiPAP and realize how much better you feel. But a lot of patients tell me that they notice that difference after they're using it consistently. Better expansion of the lungs and having more reserve in your lungs. For example, when you're getting sick, handling that a little bit better. Improving your carbon dioxide and oxygen levels, improving daytime energy, daytime focus, improving tolerance and safety of anesthesia, and then it has been shown to prolong life. So some of the risks on the flip side of not using it when it's been indicated and recommended is that without the use of it, your carbon dioxide levels will, remain high, your oxygen levels may be low, and both of these things actually strain our heart and can impact heart function, which we want to prevent since we know that heart involvement is also seen in Duchenne muscular dystrophy and Becker muscular dystrophy. You can also have high blood pressure. You can have poor quality of sleep that then leads to daytime challenges like sleepiness and fatigue. You can have difficulty thinking and concentrating, or more commonly thought of as brain fog, related to potentially seeing these high carbon dioxide levels throughout the day, or just not getting good sleep. And then there is increased risk related to anesthesia and surgery if BiPAP's been recommended and you aren't consistently using. And in fact, many pulmonologists won't let you get into spinal surgery or other big surgeries until you're showing good, consistent use, just because that risk of complications after surgery can be much higher. And then without use, it can decrease your length of life. So at this time, I'm going to pass it over to Maria, who's going to address our next two objectives. So thank you so much.
Hi, everyone. My name is Maria Gonzalez. I'm one of the nurse practitioners here at Lurie's. And I have a background in sleep medicine, and I actually was one of the nurse practitioners in the MDA clinic for 2 years with Dr. David before. So I have a really good background in neuromuscular conditions. Um, and I'm going to go over objective 3 and objective 4, understanding the challenges of BiPAP use and how a positive airway pressure, sorry, I have to move this a little bit, clinic can help address them and identify key strategies for successful PAP management, including risk stratification, proper mask fitting, side effect troubleshooting, and family involvement in care. Okay. Oh, sorry. Okay, now let's turn our focus to challenges of BiPAP use. And it's very important to really focus on these problems because they could be key in helping solutions for adherence. So the first problem is mask leak or discomfort. And this is like a very easy fit. And often just finding the right mask, a comfortable fit can be the solution to having proper adherence. And in our clinic, we often do headgear readjustment and refitting with a new mask. Another issue is nasal congestion and nosebleeds. And a solution here is making sure we adjust humidification, ensure heated tubing, and making sure that equipment is properly cleaned as well. And we can also consider intranasal steroid or saline nasal gel for comfort. Skin irritation is another common problem, and this is often due for tight-fitting masks, and sometimes oil, skin debris can also cause skin irritation. So it's very important that we look at like applying skin barriers such as Mepalex, alternating mask types, and also making sure that they have proper mask maintenance, like making sure that they're cleaning their mask properly. And dry mouth is another common barrier with BiPAP use. And when patients report dry mouth, you have to try to increase their humidity. I also check for leaks because excessive leaks can exacerbate dry mouth. And I also make sure that they're having the proper hydration. Airphagia is another common problem. And this is when air is going, they're swallowing air. And this can cause abdominal discomfort, bloating, and mild symptoms may be treated with silicone or gas X. And another solution would be reducing pressure settings or considering increasing inspiratory time and rise time. PAP brainout or condensation in the tubing is another comment that's often reported. And using a heated tubing or positioning device lower than the mask and adjusting temperature and humidifier settings is often another solution that we use. And mouth leak is a very common challenge and problem that we encounter because most of our patients have nasal mask, and we usually try to work with them as with using a chin strap. So the problems that I just addressed, these are the physical barriers to adherence. Okay, next. Okay, now we're going to continue looking at challenges of BiPAP use, but now we're going to change our focus to more of the emotional, behavior, belief, and environmental barriers to adherence. So we're going to first start with the emotional barriers to adherence. Let's start with anxiety or fear about using the mask. And this is something that we often commonly see. Patients feel like when they put the mask on that they can't breathe, that they're suffocating, and solutions to this would include systematic desensitization, counter conditioning, relaxation techniques, and most importantly, reassurance and education on safety. And Dr. Clark will further review some of these solutions. Another emotional barrier is frustration or feeling hopeless, like I can't do this, this is so hard. And we do solutions like motivational interviewing, positive reinforcement in this clinic. Also, low self-efficacy, where parents or patients feel like they don't really understand how to use this, or they have they don't think they're competent to be able to use a device. And here we do a lot of education, hands-on training, follow-ups, frequent check-ins, and really build their confidence that they're able to do this at home. Now, when we're changing our view to more behavior and beliefs adherence, and one of them is like back to perceived benefit. So some patients will say, I don't know why I'm using this. I don't see any benefit. I use it at night and I don't see a difference. And here, one of the important things is just sharing objective data, often saying, your carbon dioxide level improved, sharing oxygen levels. And like Dr. David said, really educating the why. Why is it important to use it? The benefits of use. And this is some of the solutions that I use in clinic while I'm troubleshooting this kind of barrier. Another issue is like difficulty incorporating to routine or just saying, I forgot to use it at night. I don't want to use it at night. And here we often do something called habit stacking, and Dr. Clark will further review a little bit more about habit stacking and bedtime routine and using reminders or alarms. Another barrier to adherence is environmental barriers like limited space or it's inconvenient. And oftentimes I see like I have another device, it's more cumbersome, I don't know where to fit it. And a lot of times we just go over organizational goals like optimizing the bedroom layout, having organizational aids for tubing or mats, having those loop hangers, and really troubleshooting that issues. So just like with physical barriers, emotional, physical barriers, and environmental barriers are key to identify because overall, tailoring these solutions are key to long-term success for BiPAP therapy. Now we're going to change our focus and look at the PAP desensitization clinic at Lurie's Children's. And I'm going to review how all of those challenges and those problems that we just addressed and how we're addressing them here in this clinic. So when we started this clinic, when we started this clinic, it was designed with two main goals in mind: to enhance adherence to positive airway pressure therapy in patients in the neuromuscular clinic by implementing a multidisciplinary follow-up program. And a second was to address all these wide range of barriers, including technical, clinical, and psychosocial barriers that often stand in the way of success. So this clinic includes regular follow-ups, early troubleshooting for therapy-related challenges, and family support. And the aim is at improving respiratory health, therapy compliance, and the overall quality of life. Okay, now I'd like to review what actually happens in our clinic. And I think I'm going to go over the first visit, which is one of the most important visit, I think, overall. So during the first visit, we begin with risk stratification. So we categorize our patients into either high risk, medium risk, and low risk. And this is based on download compliance, their clinical history, family involvement, recent pulmonary function tests, and their clinical and barriers to adherence. So patients in the high risk, usually these are the patients who have low tolerance, not consistent use with BiPAP use. They either have a significant surgery coming up, like a spinal surgery that need to be optimized, or they have their forced vital capacity is really low and they really need that strong support from our team to help them be adherent. The medium risk group, usually their download compliance can show consistent use, but they're not tolerating more than 1 or 2 hours. So we're really working at their tolerance, or vice versa. They can tolerate 5 to 6 hours, but they're not consistent with their use. They're very inconsistent, or they have a planned out like surgery in 6 to 8 months, and we're going to work slowly with them to help them improve their adherence. And then the low risk group is patients who are adherent. And that's where we want our patients to go. So you can go from a high risk to medium risk to low risk. So you kind of go on that scale, and eventually the end goal is to graduate from a program. Next, we identify barriers to adherence for both patients and families. Like I mentioned before, there's physical barriers, behaviors to beliefs, behavior, beliefs, and environmental barriers, and emotional barriers. And I think it's important to note that these barriers are just not randomly. I just didn't come up with them from the top of my head. They're actually organized in 3 main categories based on the theoretical domain framework that was adapted from the Adherence Barrier to Continuous Positive Airway Pressure Questionnaire, or it's called the ABCQ questionnaire. And Dr. Clark will further review a little bit more about this questionnaire. Okay. And I think the third important step is getting a very comprehensive medical history. And this is very key. We want to evaluate for dysphagia, secretion management, feedings, is feeding schedule coming in the way of like BiPAP tolerance, any daytime symptoms, recent pulmonary function tests, and bedtime routines is key too. So this structured approach allows us to get a very clear picture of each patient's unique challenges, and then that way we could tailor the treatment management. Okay, so on this next slide, I'm going to focus more on the treatment management. So our treatment management is based on 4 key factors: the patient's risk stratification, the identified barriers to patients and families, their medical history, and the family level of involvement. So the follow-up schedules are tailored based on risk level. So the high-risk patients are they follow up at least 2 check-ins within 3 months. And this can be like a MyChart message, a telephone call, another visit. And I put the word at least because sometimes we do a lot more, but we try to check with them very frequently. The patients in the medium risk, we check in at least 3 check-ins within 6 months. Again, this could be another visit, it can be a MyChart message, or it can just be a call. And then those at the low risk, we do a check-in, at least 1 check-in every 12 months. These are patients that have already graduated the program, that we're just making sure that they're doing well, that there's no issues, no new issues going on in their lives. And then we go into identified barriers to adherence. Again, the treatment for this. So for behaviors, belief, and environmental, the treatment management for this is a lot of education, making sure we remove environments and working on like motivational interviewing and stuff that Dr. Clark will further review. For emotional barriers, we do a lot of counter conditioning, desensitization techniques. And again, these are other factors that Dr. Clark will review. And for the physical barriers, this is where I do most of the component is the medical management, making sure that they have the right mask fit, making sure that that the device is working properly, and troubleshooting all of those physical barriers that I mentioned earlier. Okay. And one of the key things, part of this visit is patient and family education. So here we really emphasize why are they in BiPAP, like Dr. Pisker-David mentioned, the reasons why, the benefits why. And I think this is very key, and we emphasize this a lot during our visits. And I think a strong family partnership is key because parent involvement and family support are some of the strongest predictors to adherence. And forming a collaborative partnership and empowering families through education is something that we really focus in this clinic. So at the end of each visit, goal setting and teach back and having the patient practice is very important. And I think this is vital because it sets goals for the patients for the next visit. And it really empowers families and the kids to be like, okay, I did this at the visit. I can do this at home. Okay, I know what to do at home. And then that way they know when to call us, when to do anything, and not wait 6, 7 months and be like, I didn't do it because of this reason, right? Okay. Okay, now we're going to go over some of the physical barriers to PEP adherence and some of the medical management that can be done by providers, patients, and families. So one of the biggest things we emphasize is it's simply just keeping the device clean and having the supplies clean as well. Okay. When equipment is not cleaned regularly, it can lead to discomfort, irritation, and even non-adherence. And over time, it can put patients at risk of getting sick. So we always encourage families to follow the manufacturer's instructions. And this is a grade from the American Thoracic Society, and I give this out to families because it really lets them know how to take care of their device. It lets us know how to clean their cushions, mask, headgear, tubing, and usually I let them know cushion and pillows, they should be cleaned daily. Everything else should be done weekly. And this is just a good instructions for that. And so I think it's important to know that even simple things like oil, sweat, or debris buildup can degrade the cushion seal and contribute to leaks, and this can contribute to non-adherence. Also, dirty mask or tubing may cause irritation, unpleasant odors, or accumulation of moisture or bacteria. So this is another reason why I emphasize making sure that this device is clean and maintained. And another important thing is making sure that we replace worn parts regularly. So even if my patient's like, if it's well, there's no issue. I know that sometimes over time use the seal breaks, and this can contribute to maybe a higher leak that wasn't noted before. And now they get a new mask and that has a better seal. Okay, so now moving to one of the most important parts that I think is important is choosing the right type of mask because a lot of mask discomfort, mask leak may contribute to a lot of non-adherence. And when choosing a mask, we need to consider quality of life, safety, and adequate ventilation to making sure that it's the best fit for the patient. Okay, so now we're going to go into mask and interface options. So the mask and interface options, there's nasal wisp, nasal pillow, and nasal cradle mask. So the nasal wisp is right here at A. And I like this mask because it just provides more comfort for patients, but a lot of times patients will say they have their nasal bridge and irritation on the nasal bridge, and so that could be a little bit of a drawback. The nasal pillows, a lot of patients like nasal pillows, especially if they feel very anxious or they're claustrophobic, which is right at B. But it can cause dryness, irritation, and high pressures may be very uncomfortable. Then we have the nasal cradle, which is right here at C. And this design is to raise, just to be gently under the nose. And it tends to be more comfortable for sensitive nose, and it reduces pressure points as well. However, it may not seal as well, especially if patients are moving a lot. Now, when we go to the headgear types, there is full headgear, headgear with a back strap, and split band headgear that I like to use. So the headgear, full headgear, which is D over here, it provides the most stability, making it the best for active sleepers if you move around a lot. The headgear with a back strap uses fewer straps, which gives a simplified and easier use. And then I have the split band headgear, which adapts to better shapes of the head and helps reduce strap marks. So anyone that has like microcephaly or they just have abnormal shapes in their head, I like to use the split headgear. And this is very comfortable. And we do recommend to be used to or get comfortable with at least two mask types. So one of the, regardless of the headgear or the mask type, it's very important to adjust the headgear straps evenly and not to, and usually I just make sure that both of the sides are even, and that the goal is always a light seal. It doesn't have to be too tight because if it's too tight, it can cause skin irritation, it could cause mask leaks, and it could cause non-adherence as well. So additional considerations to help with the mask fit, as most PAP masks have a silicone air cushion. So one of the helpful tips is to gently pull the mask away when the device is on, and this helps the pressurized air to inflate the cushion, and then you could just gently put it back on the nose, and this actually helps provide a better seal, and it helps prevent air leaks. And with our patients who have nasal mask and they have a mouth breathers and they have a high leak, a chin strap is also recommended if they can tolerate it. Okay. Now I want to review the role of download in medical management and how this process can really help improve adherence. So now the first thing we look at a download review is making sure that prescription is correct, right? Making sure that the settings in the device match what's being ordered. Then we review the hours of usage, which lets us know more about the tolerance, the percentage of days used, which lets us know how consistent they are, and then the leak level. And this is important information because this is actually what helps us with the risk stratification. And other important aspects is leak assessment. High leak may be due to mouth breathing, positional leak, or poor mask feed. And always checking for mask leak before changing any settings would be very important. This is a perfect example right here of a patient who has a median leak that's appropriate, but is noted to have a little bit more of a positional leak. His 95th percentile is a little high. So for this patient, I would just make sure that there's no positional leak or mouth leak. And then when our patients are tolerating therapy longer, usually in the moderate or low risk, I evaluate for discomfort, asynchrony, and ventilation specific metrics. So some of the things that I ask are my patients, when they're tolerating it longer, are you getting a breath every time you want one? This really lets us know if there's any issues or troubles with the triggering. Oh, sorry. And then I also ask them if they feel like they're having a blast of air. If they feel like it's having a blast of air every time they get a breath, then I know that I need to change something in the rise. I also ask them, do you feel like your breath gets cut off early? If it does, then I'm thinking it's something going on with the cycle. So in short, the download review is not just about numbers. It's a critical tool for tailoring management, troubleshooting barriers, and ultimately improving adherence. And now I'm handing off my role to Dr. Clark.
Hi, thanks again for having us. I'm going to try to quickly move through some of the barriers that we encounter and what are the more behavioral or psychological approaches that we can use to help with them. And hopefully we'll save a little time for questions. So briefly, I'm a pediatric psychologist. I'm trained broadly in working with kids with all sorts of behavioral and emotional concerns. My role on the PAP team is that I try to utilize some of those strategies that we know and use in regards to specifically how they might impact a child's ability to use their BiPAP machine. I spend a lot of time just collaborating and working closely to partner with families and their medical providers. Okay, go ahead. Yeah. I know Maria briefly mentioned this adherence and barriers to CPAP questionnaire obviously was initially designed for patients who utilize just the CPAP, which is continuous positive airway pressure, but it's since been validated in many different patients, including those who use BiPAP and other ventilation supports. I wanted to present this because I think some of these things we commonly see that families don't from home, when the child's not feeling well, and we do have a lot of strategies to work with that we could spend a lot of time talking about. But I thought it was important to share some discrepancies too between the child and parent report. So we see that on this measure, children more commonly report that they just want to forget about the device. Parents don't really realize maybe that kids are kind of overwhelmed and kind of wishing that they didn't have this medical condition or the need. And then there's also discrepancies in terms of kids more commonly endorsing not feeling like they have enough support. And this is hard because even when, teens are fairly independent during the day, often we find that they might need more support and more help with utilizing the device, especially when they're getting used to it. And then just the embarrassment about using it is also slightly higher endorsement from kids relative to their parents. So we use that measure just to better assess. You're okay, go ahead. We use that just to sort of better assess what are some of the challenges that might present for each family. I want to briefly talk about why do we spend a lot of time talking about what's happening in the environment when we're practicing with our PAP device. So there's a lot of research. Many of you have maybe heard of the classic Pavlov dog experiment. Basically, this researcher Pavlov started presenting a bell every time he gave his dog food. And what he noticed over time is that even in the absence of food, the bell elicited this dog to get really excited and salivate. And so what we're thinking through with the PAP device is how does the environment at the time that PAP is presented shape their kind of tolerance and emotional perspective around it. And so what we think through is we always want to start with daytime practice because oftentimes if PAP is first presented during sleep, that can be a scary time when we're already a little bit vulnerable. Our job is really thinking through how can we pair the device with something that the kid is more comfortable with and doing it during the daytime when they're maybe doing a preferred or favorite activity. This is all called classical conditioning. Go ahead. So again, we're thinking through whether we're pairing something positive, so a favorite video game, a family dance party, some favorite activity with the mask, or something negative might be that parents doing the best they can are like, oh, my kid needs to use this device. I'm going to put it on after they fall asleep. Unfortunately, what can happen is then kids wake up and their first experience with the mask is one of fear. This is also what we'll sometimes see if they're doing a titration study before they're used to the device. What we try to do is really help them to get used to it in the daytime, doing their favorite activities so they start to get more comfortable over time. Okay, you can go ahead, keep going. So if there is, an initial fear response at first, that's unfortunately very common and normal, we use what we refer to as extinction. So the goal is that we're gradually presenting the mask without the feared outcome. So it might be that we put the mask for a period of time just out with the child's toys or favorite activities or video games, just so they see, oh, this is no longer something I'm being forced to do. It's not scary. And over time, what we see is that fear response declines. And then the opposite is counter conditioning. So basically what we want to do is, every time they get to play their favorite video game or watch their favorite show or have a special dance party with the family, it comes with the device. And basically we want it. I tell families, we want PAP use to occur during it to be like the favorite time of the day. Tons of attention from family, make it really special. Okay, go ahead. The other aspect of this, oh, and desensitization, sorry, is basically what we want to do is to continue to expose the child to their PAP device at a level below which fear is really exhibited. And so we might start with, again, like really, really slowly, gradually putting it on their face a little bit more until they're comfortable before we move to the next level. Okay, you can go forward. The other aspect of this is, so we were talking about what's happening while they're doing or using the mask. The other aspect is what do we do afterwards? And so what we know is the consequences, whether they're positive or negative, occur after their PEP is used. What we try to do is use a lot of positive reinforcement. So every time they even initiate PAP practice or try to play with it, there's tons of praise, or some, for maybe older kids or teens who are less motivated by praise, it's they get to do their favorite activity afterwards, or they get Robux or some other desired outcome. What can happen is that sometimes, not in any intention, but sometimes families will negatively reinforce avoidance of PAP usage. And so, for instance, if a kid throws a tantrum every time their PAP device comes out and the family eventually gives in, then they're learning, oh man, if I throw a tantrum, I can get out of this. And so what we try to do is, if that kid is really frightened, then again, we go back to a level where they do feel like it's more manageable and there's less fear, so that we can again use that positive reinforcement. Even if it's just like touching the mask, hey, that's progress. Yes, let's positively reinforce that. Okay, go ahead. Trying to move quickly. So the biggest, kind of the simplest technique that I would say, if I could impart wisdom today, is what we really want to use is called differential attention. Tons of positive attention. Again, best day ever whenever a kid engages with the PAP mask at all, and then removal of attention if the kid is kind of whining or complaining. So it's just this really focusing on making PAS something that's always positively reinforced. Okay. So again, yeah, great job putting the mask to your face, rather than saying, don't hit or don't avoid it, trying to limit attention for those kind of avoidant behaviors. Okay, you can go forward. I want to spend a little bit of time here. So many kids that are told you need to use BiPAP therapy initially feel kind of overwhelmed, whether it be for sensory reasons, whether it is because it's kind of scary to have something blowing at your face. One of our goals is to use this gradual desensitization process, helping them to overcome that physical discomfort or to overcome a fear like, might I suffocate? And basically what we do is we think of it using this ladder analogy. So we are starting at the bottom of the ladder with something that feels manageable. For some kids, it's like just playing head, shoulders, mask. And so you bop it on their head and on their shoulders and celebrate and sing and make it fun. For other kids, it might be that they're comfortable enough to kind of put it over their nose for 5 or 10 seconds. Often it's just getting used to, okay, take 2 or 3 deep breaths with the mask. Once they have gotten comfortable and can stay at that, whatever that rung of the ladder is, for like 4 or 5 days, then we move to the next step. So it might be, if they can do it for 5 seconds, then we move to 10 seconds. For some kids, we find that the headgear is what causes them to feel more claustrophobic. And so we might start really with just holding it up to their nose versus putting the whole gear on all at once, and gradually building. And once they can tolerate it over their nose for, 20, 30 seconds, then we might try it with the headgear loosely over their head. Slowly building until they get, again, comfortable at each level. Starting again with daytime practice. Once we see that kids can usually do this for 10, 15 minutes during the daytime consistently, then we can work on building it into the bedtime routine and eventually getting to the place where they can fall asleep. But we try to do it in a stepwise progression. Many families will say, okay, I'm starting with 5 seconds. How are we ever going to get to all night? And what we normally see actually is that once we can get to a minute or 2 minutes, the minutes build up quickly. And it actually, once we see kids who can tolerate it for 10, 15 minutes, typically they get to the point where they kind of can forget about it and it gets easier. So even though it feels far away, it often isn't as far as we might think. All right, go forward. Um, we really in our clinic try to make it fun. We're playing with the kids the whole visit and actually practicing with them together, but utilizing a kid's developmental level. So what are they motivated by? Is it by video games? Is it by stickers and celebration? We have books, The Magical Mask, that can help normalize using the machine. Thinking about firefighters or astronauts who might use the machine and how we can get kids who are interested in those things to recognize, oh, this is my cool magical mask. Okay, go forward. We use a lot of visuals in our clinic. We see that many kids like to have that physical manifestation to show, here, I'm doing it. And it's another way to just really reinforce their practice. So we give all the families a mask log. Well, I guess some teenagers are resistant, but when they're willing, and we can put a star or a sticker each time that they practice. We always try to see if families can do it twice a day, because the more that we practice, the more that desensitization comes quickly. And then one of the neat things we've been doing as we've had more and more kids who have been successful and using their machine almost every day for the majority of the nights is we give out a little certificate of achievement. And even teenagers really love seeing these and knowing that their physicians and providers are proud of them. Okay. So once kids are using the machine again for maybe 10, 15 minutes a day, can use it every day and don't seem to have a fear response or discomfort, what we do is we want to build putting the mask on as part of the bedtime routine. At the beginning, we don't care if they're even falling asleep with the machine. The most important thing is that it is something that is consistently part of their routine and that we pair with maybe their favorite step in the bedtime routine. So for some kids, it's a story with a caregiver. For some kids, maybe it's getting to listen to their favorite song. Sometimes we have to add things into the bedtime routine if it will help with this adjustment process. But pairing it so that every night they know, oh, it's story time. Okay, I'm going to put my machine on, then I can start my story, or then I can do this special activity. And what we do is at the beginning, again, putting it on at nighttime can feel a little different. And so it might be that we just have them do it every night for 5 minutes at bedtime. If they're not comfortable at that point, they can take it off. But maybe each week we add 5 more minutes until they get to the place where they can consistently fall asleep with the machine on. Okay. For kids who fall asleep easily and regularly with the machine on, but are still waking up overnight, one strategy we'll use, again, depending on age, we might call it a Pat Fairy. For older kids, it's just like saying, oh, we're going to do some parent check-ins. But the idea is we'll let kids know, okay, at some point in the night, a caregiver might come into the room, and if you're wearing the machine, we might leave you a coin or a little sticker or something special for the morning if you're wearing the mask when we come in. The idea, and you can remind kids before bed, and the idea is that many kids might kind of just take the mask off overnight, or some do it unintentionally. But if they wake up and they notice the mask is askew or not fitting right, this might motivate them then to replace it and put it back on. Oh, my parent might check in. To be successful with this, we recommend that caregivers start like within the first hour of their kid wearing it so they notice, oh, this is working and it's actually effective. And then as kids can maybe wear it for 5 or 6 hours, we ask them to check in later so that they're really seeing, okay, I've got to try to replace the mask. Okay. So thinking through potential pitfalls, I think a big thing is that consistency is key. So with any anxiety or getting used to something, what we see is that, if we use it one day and then we try it again a week later and then another week later, every time that fear response is going to rise again because it's been a while and we've kind of lost the momentum. So our key is really working with families. We know this is hard, especially with multiple kids and medically complex kids, but trying to find some time during the day when they can devote even just 5 minutes to practicing with the machine and finding something to pair it with so that everyone remembers. Getting in the habit of doing it every day. I tell families when they're first starting, I would much rather see 2 minutes show up of device use every single day than like an hour here and an hour there, because what we're working on is just developing this habit. Continuing to reinforce kids even after they're doing successful, because sometimes participation can fade over time. Again, we try to be really consistent with encouraging and checking in with families to identify any potential barriers. and really helping with the pace so that families know this is my plan and this is how I will achieve it. So they feel like they kind of know that they're on the right track and that it's moving at a place that feels appropriate for them. Okay. And so just really briefly, take home points. We know that PAP therapy is essential for helping with breathing once the muscles of breathing become more weak. We believe that utilizing our multidisciplinary clinic can be really helpful for supporting families and getting used to it. And we love to work collaboratively to try to overcome some of these barriers. So we want to go ahead and spend a little time that we have left to be able to answer some of the questions. We do have references here. But thank you so much for your time. We could spend hours talking about it and would love to at another time.
Thank you so much, Lurie team, Dr. Clark and Maria and Dr. Pascal-David. I love these webinars because I always learn a lot. And so my hope is that everybody at home tuning in or at work or wherever they might be are also learning a lot. We have a ton of questions in the chat and about 9 minutes to power through them. So we'll get through as many of them as we can. And if your question remains unanswered, you can always follow up with us, care team at parentprojectmd.org, and we can try to get some answers to your questions. But I think we can just start at the top. And Dr. Pascal-David, I think I'm going to start with you. There's just this question about choosing BiPAP versus auto BiPAP. Can you just highlight the differences and perhaps some brief use cases for the different options?
Yeah, absolutely. So, and I think I saw a question a little bit lower that also asked about different modes like IVAPs, CPAP, AVAPs, et cetera. So I might just address all of that quickly together. So auto BiPAP is a mode that is primarily used for obstructive sleep apnea, and that's a mode that automatically the machine will adjust your pressure that you get when you breathe in and the background pressure that's always present. I do not recommend auto BiPAP for people who have Duchenne muscular dystrophy because we can't really control the difference between those two numbers, and the difference between those two numbers are really important in expanding the chest. So that's the short answer. The other modes of ventilation we talk about are IVAPs or AVAPs, which is really truly, I think of it as a little bit more advanced or exciting version of BiPAP. And so truly it's still a pressure delivering mode, but what we do is we can set kind of a goal volume that we want your lungs to try to achieve with every breath. And then we give you a range of breathing in pressures to use when you're trying to get that volume. And so it helps kind of maybe get you better breathing if we're having challenges getting your carbon dioxide normal on that simple, just inspiratory, expiratory BiPAP pressure.
Awesome. I think that's incredibly helpful. There's a whole lot of acronyms and it's hard to keep them straight and understand sort of, is it a different device or a setting, or how do these things apply to the individual? A really practical question here about washing and replacing. And so I think Dr. Pascal-David, this is probably a you question. Maybe it's a Maria question. I'm not sure. How often should we be washing things like masks and replacing tubing and
Yeah.
things?
I can answer that question. And usually I recommend at least once a week to make sure we're cleaning it properly. I would make sure, I always make sure that they read the manufacturer's instructions just to make sure that there's nothing else that's different types of masks, but usually the nasal cushion, I recommend daily. Like I usually tell them to get like a little washcloth, mild soap and detergent, and cleaning out to get all that oils and skin and debris, and then getting like a clean washcloth and cleaning over it, because that really could contribute to an adherence and leaks as well. So that's something that I really emphasize in every clinic. And then everything else, I said, make sure you clean it once a week. And then I think the American Thoracic Society has a great education, and I can definitely share that link with you guys as well. And I also make sure that they use distilled water. A lot of patients are like, oh, I didn't know I was supposed to use distilled water, but that really can help prevent all of these breakdowns. And it actually, if you're not taking care of your device properly, it can cause mold, bacteria buildup, and patients can get sick. This is one of the reasons patients can get sick as well. And we don't even think about it. Like simple things that can be done by patients, families, and providers can actually go a long way in helping with adherence.
Awesome. That's great. It's, easy to not think about how things like cleaning could ultimately lead to different types of illnesses in the individual using the device. So it's a great reminder.
Yeah.
We've got a couple of questions here related to tracheostomy. So one asking, like, can you use something like a mouthpiece ventilation if you already have a trach? And then another question about potential successful reversal of trach and switching to BiPAP. Help us understand sort of the role of tracheostomy and how that interacts with things like PAP. I think maybe Dr. Pasquardev, and I'll send that one to you as well.
Yeah, absolutely. So that's a great question. So typically, non-invasive ventilatory support, which is what I'm calling BiPAP in the setting of this talk, is what we start with. And there are recommendations around when you switch from BiPAP to tracheostomy, or at least consider switching. It's well recognized now that it's acceptable to use 24/7 around the clock BiPAP non-invasively as a strategy to manage your breathing needs and your ventilatory needs. We consider offering tracheostomies to patients once they are needing 16 plus hours of BiPAP use. Or the other situation we run into is if you get sick, you're in the intensive care unit, you've needed a breathing tube for that illness, and we're having trouble getting that breathing tube out with really successful strategies. That's when we'll also get into that tracheostomy conversation. If you already have a tracheostomy, unfortunately, mouthpiece ventilation is not going to work well because it does require a good seal. And so if you have a trach, the option would be to increase time on your trach, on your ventilator during the day connected through the trach. In terms of reversing, this is not something our center has, been able to do. Unfortunately, like once you have a degree of weakness that a tracheostomy and vent has been recommended and placed for, it's tough to, it would be really challenging to remove that and switch back to BiPAP.
Great. Thank you so much. We've got another comment in here about why BiPAP is important, not only for pulmonary function, but for cardiac function too. And I think sometimes that is a point that gets missed. So I wonder if maybe we can just highlight that theme and the why behind it.
Yeah, absolutely. And so when we think about BiPAP, we know that in Duchenne, we have respiratory breathing concerns, and then we also have heart failure concerns. And the lungs and the heart work together. And so having really good support of your lungs helps remove some of that strain that your heart has to do to kind of pump blood, kind of offload some of the pressures that your heart sees. And so in our center, I collaborate with our cardiologist very closely, and, she absolutely supports us having patients on BiPAP.
I think it
Um,
highlights.
and sorry, Rachel, I just wanted to also mention that one of the things that I do in the PEP clinics, actually, I see the most recent echo and seeing that there hasn't been any changes because that also works in our risk stratifications. And I know I've communicated a lot with the cardiologist who said, this patient is um, echo is a little worse. She needs to use BiPAP or she needs to use BiPAP. Can we please work on her more consistently? And then that triggers her to be more in the high risk stratification where I'm actually following up with them a lot more frequently to help with adherence. So definitely this is where the medical review is very important in our clinic.
Well, and I think that what I'm hearing and what your team really highlights is that importance of collaborative multidisciplinary care, right? Because we're talking about something that is very respiratory heavy, but BiPAP and that compliance supports other body systems as well. And so you guys are working with your cardiologists, you're looking at those echoes. And so it really demonstrates if you don't have a multidisciplinary neuromuscular home already, there's so much importance in making sure that your team, even if they're not at the same institution, are talking to each other and sharing results and collaborating with that plan of care to make sure that it's coming together in a multidisciplinary way that's going to be most appropriate for each individual patient. So I have to plug the multidisciplinary high horse of mine. So let me see. I know we've got 1 minute left. Maybe we can find time for one more question here. Let me see. I think we've been able to really dig through a majority of the themes. I think with that, what I'll ask is for each of you to give maybe just a few more words in closing so that you all have the last word and highlight anything that we didn't talk about enough that you want to make sure that we really emphasize.
Yeah. Perfect. I guess I'll start just briefly and then I'll let my colleagues go. I think one thing I did notice in the chat that I did not highlight in this talk, but I think is very important, is someone mentioned the experience of being prescribed oxygen, so low flow nasal cannula to treat their sleep related breathing or their breathing problems for Duchenne. And I want to say out loud that absolutely no child with Duchenne muscular dystrophy should receive oxygen without the use of actually truly BiPAP. So oxygen does not solve the problem. It does not address our CO2 levels. It does not help expand our lungs. And it can actually be really unsafe because it can hide those CO2 levels and make you have trouble. So if you're having breathing problems with Duchenne, BiPAP is really going to be your first step.
Awesome. Thank you. Maria, any closing words from your perspective?
You know, one of the things that I just want to say that our clinic actually is a work in progress is still, I mean, we're still really working a lot. We've seen a lot of benefits. A lot of kids have been graduating and we're incorporating more in things and hopefully wishing to collaborate with other institutions as well. But one of the key things that I have seen is education is very key for families and making sure that they really do feel empowered and that they are able to practice this at home and collaborating from like all aspects is key. I think that that's one of the biggest take home part.
Absolutely. Absolutely. And then Dr. Clark.
Yeah, I would echo the collaboration, and we would love like parent and other providers to reach out. We always are looking for ideas from you all who have the like frontline experience. And I just want to say that we have seen so many kids who came in saying, my child will never handle this, or my teen will never be able to use this, and they have. And so there are tools, there are strategies, and don't hesitate to reach out if you need to know what those are.
Absolutely. I will take this moment to remind everybody at home, this is recorded. This is going to live as an enduring resource on our website, along with all of the slides so that you can go back and you can reference them, and should be available on our website here within the next week or so. And we've got tons of other really helpful information on our site too, whether it's about respiratory health, whether it's about BiPAP, whether it's about illness, any number of care related topics. You're probably going to find some helpful information on our site. And if you can't find what you're looking for, reach out to us. I myself am an NP by training. I've got a couple of nurses that I work really closely with. We've got a really robust team at PPMD who's ready to connect with you, answer your questions, help you find the right resources, point you in the right direction, connect you with a team, whatever the case may be. We are happy to be that additional layer of support. So please don't hesitate to reach out. With that, thank you so much again to our speakers. This was a fabulous presentation. I hope everybody at home learned something new. And thank you to everybody that tuned in. We're really grateful that you were here today. And with that, we'll go ahead and conclude today's webinar. Thanks so much, everybody.